Kinesiology of the musculoskeletal system. Chapter 1, Getting Started. I hope you guys take the opportunity to get a head start on this semester as I talked about in my letter last week. There's going to be a lot of information in this course, and much of it we want to try to tie to our therapeutic exercise course and also use it as preparation so that we're ready for our musculoskeletal course down the road. So what is the basic definition of kinesiology, and what's the big picture of this course? Kinesiology is simply the study of movement. And why? To understand what is normal and what is abnormal. So you see the video playing on the bottom left where the person, I'll show you again, where the person goes into an adduction moment and valgus of the knee. Here we go. There it goes. Now we know then that we need to use our hip abductors, external rotators, and so forth to correct that motion, right? That is why it's important to understand human movement. Why? So we can know what is normal and what is abnormal, and then how we can help the patient through whether it's joint mobilization or therapeutic exercise or simple education. So here's another example, person raising the arm. Watch what happens on eccentric shoulder flexion. You get this winging of the left scapula. You can see it there. So we identify something like that. Then what we can do is we can introduce corrective exercise to change how that works. We're doing a little slide down the wall with contraction of the scapular muscles. So that's the whole point of the course, to understand what is normal, what is abnormal, and what we can do to help the patient. So there are some definitions we're going to talk about in this first chapter, and the first of that is translation versus rotation. Translation is simply the movement of a body part or the body as a whole in a line. So for example, if we walk down the street and gait, our whole body translates forward or backwards or sideways. This is accomplished through the rotation of movement at the joint. So rotation is defined as the movement around a joint at its axis of rotation or pivot point. So that movement is the translation of center of mass. We know in our body the center of mass in an upright position lies just anterior to the sacrum. So what we do is we translate our body through space powered by rotational angular movement produced by muscles that rotate our limbs. Okay? And then again, that axis of rotation is the pivot point within the joint itself. One of the key definitions we'll talk about in kinesiology is osteokinematics, which is the motion of bones relative to three planes: sagittal plane, frontal plane, and horizontal or transverse plane. We see that on our picture here at the bottom, where we're looking at the shoulder from the lateral side. Okay, here we get flexion extension in the sagittal plane. Then the second picture is in the transverse plane, looking down from the top. So you have flexion going forward, abduction side, and what we're talking about is rotation, the ability to rotate the humerus within the glenohumeral joint in the transverse plane. And in the frontal plane, we're looking at it from the back, so we can rotate the arm out to the side into abduction, 45 degrees, 90, and all the way up. One of the most important things to understand is osteokinematics are defined by the anatomical position, which is patient in standing with the shoulders in external rotation, elbows in full extension, forearms in full supination, and wrist in neutral and fingers fully extended. So what plane does wrist flexion and extension take place in? That's right, it takes place in the sagittal plane. If we pronate our forearms so that the thumbs are pointed forward, flexion extension of the wrist still takes place in the sagittal plane. Because by definition, the wrist flexion extension is in the anatomical position in the sagittal plane, even if that motion of flexion extension of the wrist takes place in the frontal plane, such as when the thumbs are forward. Going further with our osteokinematics, we have different degrees of freedom and different motions through the joint, and that deals with the planes of angular movement in the different planes: sagittal, coronal, and transverse. So some joints possess one degree of freedom, or one motion, such as elbow flexion and extension. That's all it does. The humeral ulnar joint flexes and extends the elbow, period. Other joints have 2 degrees of freedom, or 2 motions, such as the wrist at the radiocarpal joint. Here we get wrist flexion extension and wrist ulnar and radial deviation. We do not get rotation, so it doesn't possess the 3rd degree. 3 degrees of freedom are found in joints such as the shoulder and the hip, where we get flexion extension in the sagittal plane, abduction adduction in the frontal plane, and internal and external rotation in the transverse or horizontal plane. Don't forget, joints also possess translation, which is accessory motion. So with knee flexion, as we are in an open chain environment and we flex the knee, we have concave on convex movement. That means as we roll into posterior glide position, we also glide posteriorly, right? So we're going to talk a lot about concave and convex rules for every joint in the body as we go through this course. Don't forget that joints possess translatory or accessory movement. Moving on with further information about that, we also call that joint play, right? Joint play can be found by putting your hands on patients and seeing how much motion you can move the joint in the direction that it should go. For example, if the knee is flexed at 90 degrees, we can take the tibia and move it back and forward on the femur, and there's a fair amount of motion. However, if we fully extend the knee, we're going to have very little joint play motion because it's at the end of the range. So, just like we talked about before, these translations or accessory motions occur again with following concave and convex rules. So in the anterior, posterior, or sagittal plane with hip flexion, we get a posterior translation. With wrist ulnar deviation, if you put your body in an anatomical position right now, the palms forward and complete ulnar deviation towards the midline, ulnar deviation of the wrist, actually what we get is a roll medially, but a glide laterally at the radiocarpal joint. Then, with regard to superior inferior, here's a picture of the shoulder joint going into abduction. So when we abduct the shoulder, we get an inferior translation of the humeral head on the glenoid fossa. So what's important about joint play? Well, if we have too little of it, we have stiffness in the joint, which can cause local problems and or regional dysfunction. So think about our example of the acromioclavicular, sternoclavicular joints. If they don't move enough, if they don't have proper translation, proper joint play in them, then the glenohumeral joint will be overused or underused. Overused. However, if we have too much joint play or translation in a joint, it leads to hypermobility within the joint, poor neuromuscular control, and ultimately degenerative joint disease. That is the hallmark of early osteoarthritis, is that there's a sloppiness or an increased motion within the joint. There's an increase in joint play increase in accessory motion that leads to these things. So motion is a relative thing. When we talk about knee flexion, what exactly does that mean? In the book, they're going to do that a little bit differently. The book tends to avoid open and closed chain, although it does talk about it, but they would rather talk about the tibia moving on the femur or the femur moving on the tibia. Now, ultimately, that does depend on open and closed chain, but they will try to be extremely explicit or specific within the text. With the open chain, as we remember from last semester, the distal portion of the extremity is not fixed to the earth or a stationary object. However, in the closed chain, it is fixed to the earth or a stationary object. Most motion or function in the upper extremity is in the open chain, and in the lower extremity is mixed. So with gait, we have a stance phase that is closed chain, and we have a swing phase, which is open chain. So it just depends on the functional activity we are doing. As opposed to osteokinematics, arthrokinematics is the motion between two articular surfaces, again, ruled by convexity and concavity. Most joints, there is a convex and a concave member. There are a few that don't follow that rule. And that relationship, again, dictates roll and slide of the joint. Just as a review, roll, there's multiple joint points on multiple points. Okay, so in other words, as the glenohumeral joint articulates and you go into abduction, there are many points of the glenoid fossa that articulate with the humeral head. And that roll always occurs, as shown here, in the direction of the limb. So this direction. Where the slide, it depends. It's direction dependent and depends on whether the joint is convex on concave or concave on convex. With the joint slide, we can get a single point moving on multiple points. For example, if we took the humeral head here in this position and did a manual glide inferiorly of the humeral head on the glenoid fossa, this portion of the glenoid, this portion of the humeral head would maintain contact, but along the entire or at least partial length of the glenoid fossa itself. Then finally, in a spin, we get a single point on a single point. So if you think about the radiohumeral joint, and we go into forearm pronation and supination, the articulation of the radial head on the capitellum occurs in one single point. That's a spin. Okay, so we can predict arthrokinematics based on joint morphology. I don't want to beat this horse to death, but it is, again, super important that we understand this going into the rest of the course. So we have to remember which is stationary. So when we have a convex moving on a concave, such as the shoulder joint, or a bilateral squat in this example, we get a slide or glide that occurs in the opposite direction of the rock and roll. Okay, so as we flex at the hip in standing here and go into a squat, you can see here on the right side, we get a posterior roll, but we get an anterior slide, right? They occur in the opposite direction. On the other hand, when we have a concave moving on a convex, such as the tibia moving on the femur with seated knee extension, the glide and the slide occur in the same direction as the rock and roll. So as the tibia goes into full extension, it rolls anteriorly and it glides anteriorly. So that's just like what we talked about before. Let's just take a look at that picture one more time. Here's knee flexion, okay? So as we flex, we're getting the convex on concave, so it occurs in opposite directions. Whereas when we go from knee flexion to knee extension in the open chain, we have this concave surface moving on the convex surface, so it occurs the slide glide occurs the same direction as the rock and roll. Here it's the opposite. Okay, so we touched on this a little bit a couple of minutes ago, but the position of maximum congruency, when we talk about that, we're talking about the difference between the open and the closed pack position of a particular joint. In the mid-range of a joint, generally, we have more accessory movement that takes place, whereas at the end range of a joint, and that will depend on the joint, as we'll learn through the semester, at the end range of the joint, we call it the closed pack position because it is the position of maximal congruency. That's the closed pack. The position of maximal laxity is the open pack position of a particular joint. So here, closed pack position, there is little accessory motion. We talked about the knee a little bit ago. So if the knee is in full extension, there's not a ton of accessory movement that we can impose upon the joint. This is usually towards, the closed pack position is usually towards the end range of a joint motion, where the open pack position is where there's maximum accessory motion. So there's a reason that we do the Lockman test for the knee, looking for ACL laxity in 20 to 30 degrees of knee flexion, because that is the open pack position of the knee joint. The open pack position of a particular joint will be that position at which there's maximum volume within the joint as well. So if we fall and we sprain our knee, we can't extend it all the way out because it hurts. We cannot flex it very far because it hurts. We like to put a pillow under the knee because that's the position where there's the greatest amount of room for the synovial fluid to roam around. And that's usually, again, towards the mid-range of most joints. So kinetics is simply the study of force on the body. When we talk about force, we're talking about the object's mass times the acceleration of that object. So force in this book is measured in newtons, or N, where 1 N equals 1 kilogram times 1 meter per second squared. That's the definition of force. So force acting on the body is a load. And what I want you to do is I want you to look at page 11 with me. And look at figure 1.2. So those are different loads that can be imposed on the body. We have unloaded, we have tension, we have compression, bending, shear forces, torsion, and combined loading. If we're talking about this cylinder being a bone, we can probably guess that combined loading might cause the joint or the bone to fracture more readily than the other types of movement. We also want to understand the difference between weight and mass. Technically speaking, a kilogram is a unit of mass and not weight. In the real life, 1 kilogram weighs 9.8 newtons at sea level because it's a function of gravity. Gravity acting to accelerate that body or that mass towards the center of the earth. So here we are on the earth. So this 56-pound or kilo person standing on the earth produces 560 newtons of force. If you put that same person on the moon, they're going to weigh 90 newtons, even though their mass has not changed. And here, as this picture shows, their mass is always 56 kilos. So it just depends on where they are. So that's the difference between mass and weight. So we're going to have less weight, okay, when we stand on the top of Mount Everest than we do when we're standing on the seashore in New Jersey. Here's our friend, the stress-strain curve, talking about viscoelasticity and creep once again. Creep explains why people are taller in the morning than they are in the evening. So when we lie down, our discs, which get loaded during the day and therefore water escapes from the intervertebral disc. That creep takes place at night when we lie in a horizontal position, and that disc slowly expands. Okay, we have a number of vertebrae, obviously, and that little bit of water that's replaced at night, which is creep, increases our height first thing in the morning. So just as a review, when we put stress on a tissue, as the stress increases, the strain increases. Here's our toe region where our tissues are crimped, right? They're look like an accordion, and that's just unfolding here. So we see the picture. Then in the elastic region, they're straight, and the increase in stress and strain rapidly increase. We can see stress increases as that happens. And we finally get to a yield point at which we enter that plastic region, where we get, remember, permanent deformation of tissue here. We don't want to go there unless we're talking about scar tissue. Don't want to do that. We want to stay within our elastic range and stretch in this position, remember? And of course, if we go too far into the plastic range, we eventually tear the tissue completely, and we have complete tissue failure. Don't forget, viscoelasticity is due to the collagen or the filler material within the muscles, not the fibers themselves, not the muscle fibers, but the collagen filler material within the muscular tissue. All these structures, bones, ligaments, capsule, and muscle, possess viscoelasticity, and that creep is what happens towards the end of that range. So we hold it, and there's a slow stretching of the tissue, and that's a good thing when we want to do therapeutic stretching. So we're going to talk for a moment about what we call productive antagonism, and that is stored energy from tissue load and stretch. So let's look together at figure 1.13. Okay, so what I want you to do is look at the purple dark area on the left side of that figure. And what we call that is that dark area under the curve. Now, look over at figure 1.5. We see that A in the illustration on the left side of the picture is the biceps muscle. Okay, so we're essentially winding up in order to pound the hammer in. So A is the biceps, the hammer is essentially the forearm and the hand, and B underneath is the triceps muscle, right? So when we flex the elbow, the triceps increases its stiffness, its relative stiffness. So what we see back here on figure 1.3 is that stiffness, as we flex the elbow, increases the strain and the stress within the triceps, okay? And that area under the curve is then converted to stored energy, so that when we fire the triceps, we get a quick little stretch and an acceleration or augmentation of that triceps force, because we've created energy within the triceps as we've put strain on it. That stored energy, again, is accumulated in the dark area in figure 1.3 and is accumulated, as you'll note, in the elastic region. If we push the triceps into the plastic range, we're going to actually do damage to it, and there won't be storage of energy for use, but rather tissue damage. All right, so what is the difference between internal force and external force in kinesiology? Internal force is the force produced by the muscle itself. So when we do active motion of the skeletal muscle, it's usually volitional, right? We ask ourselves, flex the elbow with a load at the hand. That's active internal force of the biceps. Where passive is produced in, again, the antagonist, as we just talked about with the triceps. So we get internal force produced or stored energy within the triceps when we flex the elbow in preparation for hitting the nail. An external force is something that's acting on the body. So that might be some sort of perturbation, or I push you, or it could be when I do a bicep curl, the load within the hand itself. So we have gravity acting on our body at all times, and we also have external loads that act on the skeletal system. Let's take a look at vector force and the 4 factors of vector force in figure 1.16. So we see that the magnitude is driven by the arrows. Okay, the arrow within the biceps itself, the internal force, is the amount compared to the external force pushing down with gravity, which is the black arrow. So one of the factors of force vectors is magnitude. Another is spatial orientation and direction. Okay, so the red and the black arrows are on the y-axis. If we think about a stress-strain curve, for example, the y-axis is going up and the x-axis is going in a horizontal position from left to right. So when we talk about spatial orientation direction in this picture, we're talking about the biceps and the external force of gravity being on the y-axis. Now, a positive or internal force is anti-gravity, that's the biceps, where the negative or external force can be a weight of the hand or gravity. Then the point of application is where the muscle insertion and the external location of load. So the angle of insertion, you can see in the picture on the left, the angle of insertion of the biceps into the radial tubercle is between the tendon and the long axis of the bone, where the external location of force is in the mid-forearm here in this example in 1.6, but if we put a 10-pound weight at the wrist, or I should say at the hand, then that external location or point of application would move far out towards the hand because of the load. So musculoskeletal torque can either complete translation of an object or a body, or rotation, as we talked about before. If we stand and we push a cart, that would be translating the cart by using our muscular force, or we can simply rotate or move our joints, which occurs around an axis of rotation. So the distance from the load to the axis of rotation is called the moment arm. So this is perpendicular. If we think about the biceps at 90 degrees versus the biceps at 30 degrees doing an isometric contraction, the moment arm is longer at 90 degrees than it is with the elbow at 30 degrees or the elbow at 120 degrees, right? So the maximum load is going to be experienced when the moment arm is the absolute longest. So here, the longer the moment arm, the more torque is produced in a standing position for a biceps curl. If we're lying down and we flex the elbow to 90, there's essentially no torque because we are along the line of gravity completely. We simply get loading of the elbow joint through the hand and the weight. So torque is the rotatory equivalent of force. And remember that force is a Newton, which a Newton is 1 kilogram times 1 meter per second squared, right? So force without a moment arm is a linear movement, such as pushing something, where torque rotates an object around an axis of rotation. So joints produce torque or movement, where when we use our body to push something, we are using torque at the joints to create translation, right? We translate a box, we translate our bodies, we translate a cart using rotatory torque forces at the joint itself. So let's take a look next at figure 1.17, where red is the positive or internal force and black is the external or negative force. Okay, the external negative force is gravity or weight, and the positive force is our muscles, right? So D in the picture, take a look at D. D is the internal moment arm. Why internal? Because internal is when we talk about internal force, we talk about the muscle. So we're talking about the distance between the axis of rotation at the elbow joint and the insertion of the biceps tendon into the radius. Okay, so that's the internal moment arm. The external moment arm is D1. Okay, we have an empty hand, so the point of balance within the mid-forearm is D1, or the external moment arm. That's the distance from the axis of rotation at the elbow and the midpoint, or the balance point within the forearm, right? Now, if we're carrying a load in the hand, that moment arm will become increasingly distal, right? So when we have internal torque, IT, and external torque is a result of muscular force, internal torque, and moment arm, and external torque is also based on, instead of muscle force, gravity or external load with the moment arm, right? Just take a look at that picture again. So, if internal torque of the muscle exceeds the external torque of gravity or a weight in the hand, then the muscle shortens, such as a concentric contraction or bicep curl. However, if the external torque is greater than the internal torque, okay, then our muscle lengthens. So if we do a bicep curl and then slowly lower it down, we can tell our brain, don't produce as much force, let it lengthen out. That's where our external torque is greater than our internal torque. And what happens when they exactly oppose each other? Here we have static rotatory equilibrium, which is essentially a musculoskeletal isometric contraction. So there, the internal torque is exactly equal to the external torque. Let's take a look at figure 1.18 on page 16. Here we're going to introduce the idea of muscular torque as it relates to a door. Okay? So we have the hinge of the door, which if you look at the top picture on the right is H, right? That's the long axis or the axis of rotation of the door. And the doorknob is the point at which we're going to actually create torque, right? So take a look at the top pictures. We have different vectors there. We have red and we have pink. So force F is trying to push on the hinge. That is not going to open the door. Forces D and H is trying to create force by pushing through the hinge. All right? That's not going to open the door. And producing force parallel to the hinge, there's no torque either. Force G will not open the door. So here's the key to muscular torque. Only a force acting perpendicular to the hinge will open the door. So if we take a look at the red arrows, C and E will open the door, where E has a greater torque potential because why? Because it has a longer moment arm. Okay? So that all relates to what we're going to talk about through this course with muscular force on bones. So if we look at the picture at the bottom, we have hip muscles where we're trying to create an external rotation force of the hip joint. Okay? So when we look at the hip abductors on the right, the production of force along the long axis of the femur, which produces rotation, will not rotate the joint. It's in the wrong position. The obturator externus on the left produces a force that goes directly through the axis of rotation of the hip, and therefore it will not create a rotation of the hip either. Only the piriformis, which is the red arrow going back to the sacrum, only the piriformis will rotate the hip because it is, as I want you to remember, it is perpendicular to the axis of rotation. That is how we create muscular torque. Very important concept. So, a quick review of muscular contraction. Concentric means coming to the center. So that, as we know, creates the lowest tension and load on the muscle and the musculotendinous unit. The internal torque here exceeds the external torque, right? Internal is within the muscle, external is gravity or some sort of load. This type of muscle contraction, if you recall, is less efficient than eccentrics, okay? And isometric is equal length. So we have a middle tension and load compared to concentric and eccentric. And we have a situation where the internal and external torques are exactly equal. And then eccentric means literally away from the center. So here we have the greatest amount of tension and load produced, and we have a situation where the external torque exceeds the internal torque. And remember, the eccentric muscle contraction is ultimately more efficient, which means it requires a less number of motor fibers to complete the same amount of force production than a concentric contraction does. So technically, a muscle contraction, you don't have to remember this for the test, but technically, contraction means coming together. So technically, a muscle contraction is strictly concentric, right? But we're going to use it a little more loosely within this course. Muscle contraction is activation of the muscle, no matter if it's lengthening, shortening, or staying the same length. Okay, muscle-joint interaction. We always have to consider how many degrees of freedom, again, that there are within a joint. So if we take a look at figure 1.20, they're illustrating here the posterior deltoid muscle, okay? And the posterior deltoid muscle does several things in 3 degrees of freedom. Even though it's a straight muscle, it is not so clean in that it does only one thing. It does multiple things potentially to the joint. In the sagittal plane, it extends the shoulder. Okay, so if we look at the person from the side and ask them to go into a shoulder extension, they use the posterior deltoid. That's its primary movement. However, in the frontal plane, if we look at the frontal plane in picture A in figure 1.2, we get a deduction of the humerus towards the scapula. And then finally, in the horizontal plane, it is capable, as shown in B, it is capable of externally rotating the humeral head in the glenoid fossa. So that muscle, the posterior deltoid, has 3 degrees of freedom. It extends, potentially, it adducts, potentially, and it horizontally works to externally rotate the shoulder. All right, so let's take a moment and think about the gluteus minimus. So here's the gluteus minimus right here. We're looking at the hip from the lateral view, the frontal plane. What motion occurs in the sagittal plane? What is it capable of doing? Take a look at its orientation on the ilium and then down to the greater trochanter. Okay, so in the sagittal plane, it produces flexion or extension. It can produce flexion, right? In the frontal plane, what does it do? Abduction or adduction? It completes. Correct, abduction. And in the horizontal plane, what is it capable of doing? Since it is the pull of the muscle is anterior to the greater trochanter, does it internally rotate or potentially externally rotate the hip? It internally rotates the hip. So the gluteus minimus can flex the hip, can abduct the hip, and can internally rotate the hip. Its primary function, as we know, is a stabilizer in the frontal plane of the hip for gait. So osteokinematics drive rotation. That's the whole point. So with the quadriceps, when we complete an open chain knee extension, because of the joint surface morphology, okay, when we complete knee extension, we get a resultant small external rotation at the end range of knee extension. And you can expose your knee and try that. Watch it as you go from 60 or 80 degrees of flexion. You extend the knee slowly. Watch what happens to the tibia at the end range. It goes into a little bit of external rotation. That's why during this course you have to know your anatomy. You must know your origins, insertions, and joint surfaces, because the origin insertions are going to dictate the pull direction, and the joint surface, as in the case of the knee joint, is going to dictate what happens at the joint itself. And this is true everywhere and dramatically true in the cervical spine, as we'll see later. All right, so do contracting muscles always produce the same result? Let's take a look at Special Focus 1.4 at the bottom of page 19. So, usually they do. However, a contracting muscle, here's what's important to remember, a contracting muscle will move the freest segment of a joint. So if you read through, and I want you to do this, read through the special report in 1.4, you're going to find that it's talking about the scapular muscles. Okay, so just remember right now, for our purposes today, that contracting muscles move the freest segment, and that makes sense. Loosely speaking, this is the concept behind those syndromes we talked about for lumbar flexion extension, for hip anterior and posterior glides. Okay, so for the shoulder, the hip, and the spine, loosely speaking, this freest segment has a great deal to do with the patient's, for example, in lumbar spine, their direction of preference and the forces that caused the problem in the first place. It's also related to that concept of relative flexibility. I know this was a long time ago, but think about this. If we lie one of our subjects on the table in a prone position, as shown in this picture here, and we passively flex the knee, what will generally happen is that it won't be until 120, 130 degrees of knee flexion until we get compensatory motion here in the hip and lumbar spine. But if our quadricep is quite a bit tighter than our lumbar spine, so we have a lot of lumbar spine extension available, then this might happen very early, even though the quadricep is not all that tight. Okay? It's just stiff. So when we flex the knee with the patient prone, if we see very early rotatory motion here at the hip and the lumbar spine, what it tells us is that the relative flexibility of the lumbar spine is greater than the relative flexibility of the quadricep. So that prone knee bend results in early lumbar spine extension because the lumbar spine is more flexible than the relative stiffness in the quadricep. So there's some different examples of that through the body, but that's probably the best one. But just remember, when a muscle contracts or it's stretched, its action is going to take the most result upon the freest segment or groups of joints that it acts upon. So moving on with muscle action, we know this well, antagonist, agonist, and synergist, just to review. So an agonist is technically any muscle that does a desired action. So think about wrist extension. What muscles create wrist extension? Well, we have a few, right? We have the extensor carpi radialis, we have the extensor carpi ulnaris, we have the extensor digitorum, and we have potentially extensor pollicis longus. Technically, we have the extensor indices and the extensor digiti minimi. Those potentially can. So they're all agonists for wrist extension. All right. So in our course, we're going to talk mostly about what the prime mover is. All right. So what is the prime mover for wrist extension? Well, it's the pair of the extensor carpi radialis and the extensor carpi ulnaris. Right. So what is the prime mover for forearm supination? Think about that a minute. What are the muscles that cause form supination? You recall that the supinator does, obviously, at the radioulnar joint, and that the biceps does. Okay? So really, unfortunately, it depends. So the prime mover for form supination pronation with the elbow extended is the supinator. But the prime mover with the in standing and holding the arm at 90 degrees, we're already activating the biceps. The primary supinator in that position is the biceps itself. Okay. The antagonist, as you recall, is the muscle on the opposite side of the joint. Okay, so the antagonist of the biceps is the triceps. Now, where it gets a little tricky is the synergist. And what is a synergist? A synergist is a cooperating muscle to create the correct action. And it's important to recall or to understand that synergists can be antagonists or agonists. We're going to talk about that in the next slide. So more on synergists. Think of synergists simply as helpers. We know what our prime mover is. All the other muscles that are involved, okay, are, whether they're antagonists or agonists, are synergists. All the other muscles that are contracting are synergists, and then we have the prime mover. So if we do standing hip extension, our prime mover is the gluteus maximus, right? And then there are different synergists that help us do that motion. So we're going to break down our synergists into three different categories: stabilizers, neutralizers, and fixators. So first example, the blank is a synergist for the deltoid during shoulder elevation. Okay? In other words, this stabilizer assists with control of arthrokinematics of the shoulder. Okay? So a stabilizer is close to the joint and creates action close to the joint to control movement of the prime mover. Control motion of the prime mover. So the stabilizer in this case is the rotator cuff. The rotator cuff is a synergist or helper for the deltoid during shoulder elevation. If we did not have the rotator cuff to drop the humeral head within the socket, then we could not raise our arm overhead because the deltoid would simply pull the humeral head up into the acromion arch and nothing would happen. So here, stabilizer, just remember, it's close to the joint and helps with control of the joint and what's happening. A neutralizer opposes the extra motion of the prime mover. Okay? So if we think about hip extension, when we extend the hip, we use the gluteus maximus. What is the other motion that the gluteus maximus does? The gluteus maximus does hip external rotation. So therefore, what we need when we extend the hip, unless we want to turn the foot out and look crazy, is we need a neutralizing muscle to oppose the external rotation so we get a pure hip extension movement, right? So as I extend the hip, it wants to external rotate because that's what the gluteus maximus does. We need to use an internal rotator muscle to keep the gluteus maximus from externally rotating at the hip. So those are neutralizers. So in our example, the foot's extensor digitorum brevis is a synergist for what muscle in gait? Extensor digitorum brevis does what? It does dorsiflexion and eversion, right? So the prime mover here during gait for dorsiflexion is anterior tibialis, right? But anterior tibialis does dorsiflexion and inversion. So we would look a little bit funny walking along, pointing our toe in every time we cleared our foot. So the extensor digitorum brevis is the synergist, the neutralizer, to keep the anterior tibialis from going into or pulling the foot into inversion. Finally, we have fixators. So fixators control proximal joints, such as cervical spine, lumbar spine, and the scapulothoracic joint. So really fixators we can think of as our core, right? We need a stable base of support from which our distal extremities work properly. So the blank is a synergist for hip extensor control of the pelvis. So if we go into hip extension, what muscles are going to control our pelvis from going into an excessive extension or anterior tilt posture? What is the fixator? Our hip goes into extension. We need to use our abdominal muscles, right? So our abdominal muscles will control our lumbar spine from going into excessive lordosis or extension or anterior tilt as the hip goes into extension. So the classic example here is when we throw a baseball, we need our scapular muscles to fixate properly the scapulothoracic joint. So we have good proximal stability, okay, for good distal mobility. So those fixators are core muscles, scapular muscles, deep neck flexors, abdominal core are our synergists, our fixators for muscle action. All right. Additionally, synergists can be thought of as a force couple. There are a few of those. The primary one we have in our body is with scapular elevation. So we know that those muscles act together to produce the same rotatory force. That's a synergistic force couple. Synergistic force couple is muscles acting together to produce the same rotatory force. So the blank lower trap above 90 and the serratus anterior work together to produce upward rotation of scapula during shoulder flexion. Well, you know that the upper trap does, right? The upper trapezius and the serratus anterior below 90 degrees work to upwardly rotate the scapula. That's a force couple. Once it gets above 90 degrees, our lower trapezius helps to crank that even further, all right? So when we talk about synergistic force couples, we're not talking about Tom Brady and Gisele Bündchen, okay? As wonderful as they are, they're not the force couple we're talking about. We're talking about force couples here. All right, last thing we're going to talk about in this first chapter is musculoskeletal levers. And there are three types of levers to produce joint motion, okay? So our first class lever is analogous to a teeter-totter, where the axis of rotation is between the load, internal and external. So the example they give in the book is the zygapophyseal joints of the cervical spine. If we let our head muscles just relax in standing, our head would fall forward, okay? So this here is the external load. This is the internal load here, okay? The extensor muscles of and stabilizer muscles of the cervical spine, okay? So here we have the axis of rotation occurring between the external load and the internal load. When we get hyperlordosis, we have the extensors dominating to even a greater degree, okay, causing an increased lordosis because of weakness of the antagonist muscle, which is still a synergist, really. Even though it's an antagonist, it's a synergist to keep the head in a neutral position. So that's a first-class lever. There's not a ton of those in the body, but this is a good example. Second-class levers are very rare. In fact, we're going to just talk about one of them. And the analogy here is a wheelbarrow, okay? So we have a load here. Perhaps we have 200 pounds here, but because the load is close to the axis of rotation and our internal force is out distally here, all right, we don't need a lot of force to do the activity with our wheelbarrow, right? We can have 150 pounds here and lift it using perhaps 40 pounds here. So here's your example. Here's the fulcrum. Here's the load. And because and of course, the closer the load here, the less effort there is. If the load was all the way out here, then we'd have a lot of effort. But here, if the load is here, for example, very little effort. So let's take a look at the example in the body. It's standing calf raise. So red arrow is the center of mass. In other words, that's the position where all force is balanced on the foot. It's in the midfoot and goes up through the knee, up through the hip, up through the spine, and finally to the head. Right? That's the center of mass. The axis of rotation for calf raise is the first metatarsal phalangeal joint of the great toe right there. That is the axis of rotation for the motion as we come up on our toes. And the internal muscular force is, of course, the gastrocnemius complex here. So here we have our axis of rotation, which is actually distal to our center of mass. So it doesn't take a lot of force to go up on our toes because the center of mass is between our external force and our axis of rotation. Okay? So that is our second class lever. That's the only one we're going to talk about. And finally, we have our third class lever, which is our most common lever in the human body. So here, the rotational axis is proximal to the internal force. If we go back here, the rotational axis here is distal to the internal force. That's why it's so easy relatively. Go back here. We have the biceps insertion on the radial tubercle. We have the axis of rotation here in the elbow. So here's the schematic. Here's our fulcrum, elbow. Here's our effort, biceps. And here's our load at the hand. All right? So our moment arm is here. What is that, internal or external? It's internal. Internal force, muscle. External force, load. So our internal moment arm is here. Our external moment arm is here, right? So I'm going to blow this up a little bit so you can see it. Just a very simple, it's not a true calculation. It's just real simple to visualize. So in this picture, we have a 1 pound soda can here in our hand. If the external moment arm is 10 inches, arguably, and our internal moment arm is 2 inches, then what we have to do is divide 2 into 10, we get 5. So what we have to do is we have to multiply the load at the hand times 5. And that's going to be the force of the muscle. So you have to produce 5 pounds of torque, positive internal torque, on the biceps to hold a 1 pound can of soda. If this were 7 pounds, what would this force be? It would be 7 times 5, okay? 10 divided by 2 is 5. 5 times 7 is 35 pounds, right? So that is our third class lever, the most common lever that we use in the body. So what is the difference between these? Briefly, because we're going to talk about this in biomechanic lecture later on, but briefly, a first class lever, the load, the external load, and the muscle force are going to be variable depending on the math, because it's going to depend on the distance of the external load and the internal force from the axis of rotation. However, with a class 2 lever, its mechanical advantage is greater than 1. In fact, it's closer to 4. So if I'm 100 pounds of weight, okay, I can probably exert about 25 pounds of force here, internal torque, in order to come up on my toes. So it's not a difficult thing because the axis of rotation is out distally here, and our center of mass is here. And when the center of mass is between the axis of rotation and the internal force, then the mechanical advantage is greater than 1. All right, so it's easier. It requires less force than the actual total load. That's a class 2 lever. In our class 3 lever, our mechanical advantage is less than 1. We just talked about that in the last slide, because this is 2 inches, this is hypothetically 10 inches, so it takes 5 times the amount of internal muscular force to hold an object out here. So here's 1 pound, 10 divided by 2 is 5, 5 times 1 is 5 pounds of muscular force. So what we have here, and it's most common in our bodies, is a force penalty. And that's going to produce a joint reaction force coming down like this into the elbow joint. And that's why we need all the good protective stuff within our joints, because most of our joints are class 3 levers, and there's a force penalty which requires us to create a fair amount of internal joint reaction force to produce a relatively simple activity. All right, so that's the end of our lecture today, and I'll try to get you chapter 2 in the next couple of days. Thanks, guys. Have a great rest, and we'll talk to you soon.